If you look around, you can see that body fatness is a bigger problem now than it used to be. The statistic going around is approximately 45% of Americans are obese measured by BMI. But if we measured obesity as body fat as a percent of total body weight, the metric is closer to 90% because of the many people who don't look obese but have high fat combined with low muscle mass. And what is even more concerning for us wise athletes is that the level of body fatness that is unhealthy varies dramatically between people because the location of the fat is what matters. Some people, even very fit-looking people, have a very low threshold for fatness before they begin to experience metabolic problems that are associated with obesity, including higher rates of cancer, type 2 diabetes, and cardiovascular disease. So what's my threshold for unhealthy fat? What's yours? Today on episode 135, Dr. Vyvyane Loh joins the show to explain what is happening to our bodies and why. And thankfully, she shines a bright light on the pathway to metabolic health and athletic longevity. Dr. Loh is board certified in internal and obesity medicine, and she runs a medical practice helping people of all shapes and sizes to solve metabolic health challenges. And she has answers to my questions on how to find my own unhealthy fat threshold and how to avoid the excessive catabolism that comes from sitting too much, overweighting endurance exercise, eating too little protein, intermittent fasting, frequent dieting, and more. Yeah, this is a good one. So strap in and let's talk to Dr. Vyvyane Loh. Dr. Vyvyane Loh, welcome to the Wise Athletes Podcast.
Thank you for having me.
Well, I appreciate you making some time for us here. I have to say, I was unaware of your existence in the universe until very recently, and your obvious intelligence attracted me to listen. I invested a lot of time in listening to all of the many things that you weigh in on. You are amazing. I just want to say that for the record. Today, I think we're going to focus on your main thing. I think you run an obesity clinic.
Yes.
Is that right?
Yeah, I'm board certified in internal medicine and also obesity medicine. I actually like to think of it as a focus on metabolic health because I treat most chronic diseases and most of them really are metabolic diseases. So obesity is a metabolic disease, but I also treat low muscle, right, and low bone. So these are all metabolic tissues in the body. And as an obesity doctor, I think a lot of people think about weight loss when they come to see me. And unfortunately, most of the medical world thinks about obesity in terms of weight or let's say your BMI. However, actually for me, it's about the metabolic tissues in your body because, when we talk about metabolic health, it seems really odd to me that most times in the medical world, we completely ignore the main metabolic tissues, which is your fat, your muscle, and your bone, right? I mean, obviously, we have the liver coming into play and the brain, the central nervous system. But, really the largest components of the tissues in your body that make up the metabolic organs will be fat, muscle, and bone. And we hardly ever discuss them in detail.
Well, we're going to talk about that here today. I want to point out that the audience here is probably not obese, although I have heard you say that 90%, if you use body fat as the guide, 90% of Americans qualify as obese, and I'm curious to understand that a little better. I think that the audience here is in that 10% that aren't, and what they want to know at some point here in our talk is your advice on how can they avoid these metabolic problems. And maybe they've already started showing up, whether it's maybe they're losing bone density or they're putting on a little extra body fat around the middle, or they're losing some muscle mass and they're not really sure what's happening there. And so they're starting down that path. They're not there at the end where there's a terrible problem, but they want to not go there.
That's right.
So that's what we want to get to the bottom of. But this is your story. Go ahead.
I guess this is my favorite audience because, really sometimes people aren't really that invested in their health, right? Everybody says health is important to me, but they don't invest in it. And it sounds like with your audience that they're used to thinking about their bodies as instruments. And so they're training and they're worried about their nutrition, right? And how to optimize. And you don't often come across, people who have that level of sophistication when it comes to their body functions. In terms of where we start with body composition, I do always start with fat. And as you said, I always have been telling people there's a lot more obesity going on than we realize. By BMI, 42% of the country has obesity, and that was from NHANES 2018. If we were to kind of be more up to date, I think we've gone closer to 45% post-COVID. Because, I think just the lockdown itself, where people were at home and they were self-soothing with food, the level of obesity by BMI went up. However, what we're completely ignoring is something called normal weight obesity. Because when we think about obesity, we're just going by weight or BMI. But if you think about it, right, someone loses 5 pounds of muscle and gains 5 pounds of fat, well, they're going to be weight neutral. So when they step on the scale, nothing happened, and they think they maintained their weight, but they're drastically different metabolically because their whole body composition has changed. And so I've been trying to get people to stop thinking about weight per se or BMI. And I always tell people losing weight will probably make you sick and fat.
Wow.
Right. And I'm gonna try and explain that. So let's start with normal weight obesity. It doesn't matter what your weight is. And I have had patients who are, 100 pounds, 110 pounds maybe, and their BMI is completely normal, not even in the overweight category. But when I check them by DEXA to assess for body fat, it turns out they're in the 40% body fat range or 38% body fat range, right? Which puts them in the category of having obesity. Now, again, if you looked at these people, you did the eyeball test, they're going to look normal, they're going to look thin. So these are the people we completely miss with obesity. We think, oh, so-and-so looks thin, he can't have obesity, right? But if we were to put him under a DEXA scan and, we find out that he's 30% body fat, he has obesity no matter what his weight is. So I always say this is regardless of weight. So if your weight is normal or your BMI is normal, does not mean you don't have obesity.
Let me ask you a question. I just want to make sure I understand what these percentages mean. When you say somebody is 30% body fat, does that mean that
30% of your weight?
The weight.
Yes.
So if they're 150 pounds, then
50% would be 75.
Wow. So of their bones, so they're like their muscles are way less than half if they're 50% body fat.
Yes. And that is abnormal. It shouldn't be that way.
Okay.
But we completely miss this. And now you have someone who looks thin, but is already metabolically compromised, right? And these are the people, they just keel over one day and everybody goes, oh, but he was so healthy. He jogged every day, he looked like he was in the prime of health. And people are shocked. And I'm like, no, you can't just look at someone. You can't go by the eyeball test, right? So now, in terms of people who are exercising and those patients who come to me who are maybe just more concerned about their health, they go to the gym, they take care of, how, they function by increasing exercise. The problem there is often they'll come to me, and I've had doctors come to me and tell me they were 4% body fat. Now, this is a huge problem.
4%?
Because 4% body fat by definition is a very, very dangerous condition called lipodystrophy. Okay. And
Or a professional bodybuilder.
No, not even a professional bodybuilder.
Oh, wow.
Lipodystrophy is a very serious medical condition, and it's really characterized by having no healthy fat. And most of this healthy fat is subcutaneous, is under the skin. So if you can pinch it, it's subcutaneous. That's what it means. The pinchable fat is actually protective metabolically, at least to a certain point, right? And when you have no more space in the pinchable fat, then it's going to spill over somewhere, and it spills over internally into organs, into tissue, into your heart, into your liver, into your pancreas, right?
Into your
Lungs,
muscles even?
and into the muscles. Yes. So now we have what we call ectopic fat, which just means it's out of place. You shouldn't have fat, in your liver, for example, right? And you shouldn't have fat, in your lungs. So if it's there, then it's out of place, and we call it ectopic fat. And the reason you have it is because you've run out of space in the subcutaneous compartment. Now, some people have a larger subcutaneous compartment. And so they are actually protected from some of these metabolic abnormalities. But especially men generally have a very small subcutaneous compartment. So when you look at the DEXA scan, you see they don't have much subcutaneous fat. And so all the fat is in the gut, inside the belly, what we call visceral fat, right? It's associated with the intestines and so forth, and the organs inside. That is the fat that will kill you, right? Now, so when someone says to me they have 4% body fat, it's either they don't really understand what that means, and also they've had a very inaccurate way of measuring their percent body fat, right? Or they really are very sick. If I were to see someone who truly has 4% body fat, he or she would have a swollen belly from an enlarged liver that's gorged with fat, right? And they will have abnormal body structure because there's no subcutaneous fat. They may have very skinny arms and legs, but big, swollen bellies from all the fat that's accumulated inside. These people have massive insulin resistance, right? And liver fat. They go on to get liver cirrhosis. They die very young, right? So lipodystrophy is a very serious medical condition with very advanced metabolic dysfunction and abnormalities. Very hard to keep these people healthy. If you were to transplant fat to the subcutaneous compartment, it actually helps them regulate their metabolism better. So the reason that someone would say to me, most common reason someone would say to me, he is 4% body fat, is because they're using that handheld bioimpedance device at the gym that their trainer, provided them with. And that is highly inaccurate. So I'm going to say to your listeners, if you're a guy and you've used the handheld bioimpedance device to get a measurement of your body fat, if you're a guy, I would add 10 to 15% to that number. If you're a woman, you need to add 20 to 25% to that number.
So they're not adding percent, they're adding percentage points.
Yeah.
Instead of 4, it's 19.
Correct.
Okay.
Yes. I've never been wrong, right? I do the eyeball test. If they're on the leaner side, I go on the lower end. So for the men, 10 to 15% points, I would choose the lower end, the 10. Right. The women minimum I start with is 20 to 25. Okay. If we go by percent body fat and we measure it accurately, you would be defined as having obesity as a man if you had 25% or more body fat. For a woman, it would be 35% or more. Some institutions use a lower number. I tend to be more generous, so I go with the 25 and 35. Right. So the only way you'll really know is to get a proper measurement. And usually that's, the gold standards would be CT and MRI, but they're not very accessible. So the DEXA body scan is the way to go, right? And that's just a simple x-ray with very, very low radiation. It's so low that children can do it, babies can do a DEXA scan.
Sure. And people are used to this for getting their bone scanned, right?
Absolutely. So it's just a different software that they have to apply. So wherever there is a facility that does a bone density scan, they could technically get a body scan, but some of these institutions may not have the body scan software. So you'd have to ask.
And maybe they don't know what they're doing. I assume that there's some skill in doing this as well.
There is some skill. The technician does have to know what he or she is doing, but I will tell you that most doctors are unaware of how to use the DEXA. to measure body composition. And that's really unfortunate. I had a radiologist call me and ask me about the DEXA scan, right? I'm not a radiologist, but his big thing was, well, we've been using another a bioimpedance device. And I think they probably used a Sika, which is more accurate. But still, he was startled at the big difference between the old instrument and the DEXA. He said, this is not real. This is not possible. And I said, can you just read me some of those numbers? And I said, oh, that's real. That's real. They're a lot higher than he was used to seeing with the bioimpedance devices, right? And I'm like, no, that's real. Let me tell you, I've been doing this for years. That's real, okay? So it doesn't matter what your weight is. Main thing to remember is you do need a more accurate way to assess obesity, and that would be to get a DEXA body scan and figure out how much of your weight comes from fat, right? The percent body fat. That's number one. The other thing we need to know is, where is that fat? I just told you the healthier one is under the skin. So we need to figure out how much visceral fat you have. And with the DEXA, there is a way to figure out, to guesstimate the amount of visceral fat that you have. And, that would be, for me, the target when I'm treating someone, right? I'm not treating for a weight. I'm not treating to get you to a certain BMI. I'm treating to get you to a certain level of visceral fat that I consider metabolically safe and healthy. So that's my metabolic goal for my patients. So that's number one, is that people may think that they don't have obesity, but actually they might. And I have said, when you walk into a room and there are 10 people in the room, it's likely that 9 of them have obesity, right?
Nobody wants that label. I mean, nobody
Right.
could stand themselves to say, oh, I'm accepting that that's what I am. But what really matters is the metabolic consequences of that, I think.
Huge. So if a woman thinks she's normal weight, right, and she thinks she's fine, but she actually has increased percent body fat, so she has obesity by percent body fat, actually she has a much higher risk of invasive breast cancer and also of spread of the breast cancer, right? So we're not actually now assessing risk in this person accurately because we think, oh, she's thin, she's fine, her weight's normal. But actually you've missed something. You've missed that she's at high risk because she has increased percent body fat. And that's just one thing. Increased percent body fat is associated with a lot of inflammatory diseases like inflammatory bowel disease, for example. If there's a lot of this bad or dysfunctional fat around your heart, then you're primed to have atrial fibrillation. I see a lot of patients with this irregular heartbeat, right? And if you don't get rid of the fat that is kind of surrounding the heart, you can't get rid of all of it because some of the fat there is normal and protective, the pericardial and epicardial fat. But any excess needs to be removed, right? You have to get rid of it because otherwise it's going to keep irritating the heart. Because if you remember, fat is an insulator. And the way we generate the pumping action is we have a node that sends an electric current, right, to the part of the heart that pumps. Now, if you have fat infiltrating into the heart, it's going to interfere with the conduction pathways, right? And we have problems. And don't forget that fat is an endocrine organ, so it's not just a storage organ. It secretes a lot of hormones. And it secretes also inflammatory signaling molecules that we call cytokines. And this irritates the heart muscle, and that might provoke an arrhythmia as well. So if you're not going to get rid of the excess ectopic fat, you're not going to get rid of the arrhythmia, you're not going to get rid of the inflammatory bowel disease, you're not going to decrease your risk for cancer. 40% of cancers are due to obesity, right? So, it can go on. And also like COPD. So in 2019, I think they verified that they could find the ectopic fat in the lungs, and this can provoke asthma attacks and, chronic obstructive pulmonary disease, right? So people don't think about fat when they think about these diseases.
And people who have been listening to the podcast and who have been tolerating my excursions into longevity medicine, they've heard about the hallmarks of aging, and chronic inflammation is a hallmark of aging.
That's right.
So it is a factor behind all of the diseases associated
Absolutely.
with aging.
So let me tell you that when you have this dysfunctional fat inside the belly, it's very distinct because it doesn't grow like, and yes, you make new fat cells. Everybody thinks you're just born with whatever you have. That's not true. You do have a turnover, but basically your body knows how to keep a constant number. So they do turn over, but it kind of keeps a constant number. But the way that you would, increase fat in the subcutaneous tissue, the healthy compartment, is by a process called hyperplasia, which just simply means making baby fat cells, right? So the little fat cells, there are stem cells in the fat, right? We think of fat as just a fat cell, but fat sits in a bed. I like to think of it as a nest. And this bed has blood vessels that perfuse it, and nerves, and also a lot of immune cells and connective tissue, and also stem cells that sit in this bed, along with the fat cells. I think the fat cells themselves are just 40% of your fat tissue. So a lot of it is actually the immune cells and other what we call stromal cells, right? And they support the fat cells. So they act as little nursemaids to keep the environment healthy and clean for the fat cells. So when you have healthy fat, the way they reproduce is those stem cells will reproduce and we make more baby fat cells. So now if you had 10, we make another 10, we have 20. All right. And if you're eating excess fat, those extra 20 cells will absorb the excess. Okay, well and good. And the other thing I want you to remember is as we're growing these new baby fat cells, we're also adding more blood vessels and supplies and nourishment for the fat. Okay, this is not the case with the fat that's inside your belly. It grows by a process called hypertrophy, which means it just swells. So it's not making new baby fat cells. It's swelling like a balloon. All right. Now, the problem with this is the plumbing to the fat hasn't increased. So you're not increasing blood vessels to bring in more oxygen and nutrients, and you're not, having more blood vessels to take away waste product. So you're going to have a plumbing problem directly. And what happens is, as the fat cell starts to increase and swell up and become bigger and bigger, like a bigger balloon, there are going to be areas inside the cell that will not get enough oxygen, right? The blood supply is not going to be enough to, get the oxygen diffused right through the entire cell, which is now bigger, right? And also nutrients, right? We're not increasing the plumbing, so we just have the same amount of oxygen and nutrients going through, but now the cell is a lot bigger. Cell volume is huge. So now what happens is those cells start to die. So people who have a lot of ectopic fat realize that you have a lot of cell death within the body. Okay? And this is not healthy cell death because your body will start, those fat cells will start to signal, help, we're in trouble. We don't have enough oxygen. We don't have enough nutrients. And they will signal the immune cells by sending out these inflammatory molecules that we call inflammatory cytokines, right? And so as the fat cell starts to swell, we're making a lot of tumor necrosis factor alpha, TNF alpha, interleukin 6, interleukin 1b. So all of these are inflammatory markers and inflammatory substances. And this will irritate the neighboring organs, the viscera, the heart, anything that's inside. It gets into your bloodstream, for example. And that is why we say obesity is an inflammatory condition. It's a condition of chronic inflammation because those fat cells are chronically now making these molecules that signal inflammation to your immune system, right?
But I guess it's different. What's too much might be different from person to person. Some people can have more of the subcutaneous fat that is healthy, and they could get a lot of that, whereas another person maybe can't have hardly any of that before they start going into this unhealthy fat. And so they've got these
Absolutely.
metabolic problems, even though they look skinny.
Right. So it really depends on the subcutaneous compartment and basically its capacity. Because once and that's why you can see people who have obesity but still seem to be metabolically healthy. However, usually within 7 to 10 years, they will convert to a metabolically unhealthy profile, right?
I see.
They tend to convert because over time, even the subcutaneous cells will start to get stressed because don't forget, they are also receiving a lot of the inflammatory signals from the visceral fat, right? So it's signaling the entire body, and the subcutaneous compartment will also start to get stressed, right? And then we get into trouble.
Okay. So it shouldn't be thought of as you can have as much fat as you want up to a limit and you can have that amount of fat forever. You can sort of flex up and down and you can go up to that amount, but you shouldn't stay at that maximum amount even.
That's right. I think you hit it on the head because basically we need that metabolic flexibility. That's how we survived through the ages, right? We we didn't have refrigerators, so we had the fat to carry the nutrients for us. In times of famine, we could use that. So you had to have this store that could go up and down, and it's made to go up and down, but it shouldn't be stuck chronically at a high level.
Or even at a low level. There
Yes.
should be just some healthy amount
Yes,
that you sort
absolutely.
of operate above and below.
Yes, absolutely.
Okay.
So, the first component that I think your listeners should start to think about in terms of their body composition is percent body fat and where the fat is, right? Whether it's inside or subcutaneous. And then there are other interesting things that we could add in there. Brown fat, for example, which is very metabolically active, right? And some people try to biohack their bodies by increasing brown fat with cold exposure and so forth. So, that would be the extras. But first, you have to know where you're at. And also, you have to target the visceral fat.
Yeah. And I understand that the DEXA is going to be the best way to do it. You're going to get a lot of accurate information, but not everybody has access to it. In fact, I don't have access to it where I'm living right at the moment. And so, what I have done in the past, and maybe I've fooled myself, but I've always thought that it was in the ballpark, was using the charts of photographs of people, of men's trunks and
Oh, yes.
trying to
Okay.
compare what my trunk looked like to,
Good.
that was
Good.
12% or 15% or
Yes.
18%.
Excellent. Joe, I'm so glad you brought that up
Okay.
because actually, in one of my slides, when I do presentations, I showed MRI transverse cut, right?
Uh-huh.
And these people have the same waist circumference, but you can see on each cut that they have different amounts of visceral fat.
So even the guy with the six pack, he might still have ectopic fat inside the six
Yeah,
pack.
yeah. So when I show the MRI cuts, the transverse cuts, you have as little as under 1 liter of visceral fat, and then you have almost 4 liters at the same waist circumference, different
Uh-huh.
individuals. So it's
Uh-huh.
really hard to tell. Right? It's
Okay.
really hard to do the eyeball test. Some of the other ways, like now, some people do use the Sika, and it can give a more decent percent body fat measurement, but it won't compartmentalize the fat. In other words, you can't tell, is this all subcutaneous? How much visceral fat? So
Yeah.
that's the limitation, I think.
Could people use maybe something like that combined with maybe some inflammation markers, blood markers, to get a sense, do they have chronic inflammation in their body, CRP or something like that?
Yeah, I mean, I think the problem with CRP is that, it's so general. You have a bad night's sleep, your CRP is going to go up. It's a one point in time, right?
Yeah.
Measurement. It's supposed to be a proxy for interleukin 6. Interleukin 6, the function of interleukin 6 is very interesting. It has homeostatic functions, it has inflammatory functions. You can't get rid of it because it's really important for health. But again, too much of it, and it's not even just the levels, it's the type of signaling and in what tissue can affect your body very differently because it signals in different pathways, what we call
Okay.
classical and alternative pathways. And it makes a big difference.
All right. So if you really want to know, get a DEXA.
Yeah, a DEXA is really important. And
Okay.
then, let's look at the next component, which I think your listeners are really interested in, which would be the muscle component.
Mm-hmm.
All right. So we have to realize that normally in a man, I would expect 55 to 60% of your body composition should be your lean mass, right? But I'm not seeing that generally. It's usually more fat, and it's the same in the women. It's much more fat than the lean mass.
And what is lean mass? Is that my muscles?
Muscles and bone.
Okay,
Muscles
so
and
it's
bone.
it's everything except the fat.
Yeah,
Okay.
yeah. So, and because on a DEXA, we can look at least the bone mineral content. So we
Mm,
can subtract out the minerals in the bone, which do add weight, right?
sure.
And that way you get a closer estimation of just muscle. You see what I'm saying?
So like muscle and organs, I guess.
Muscle and organs. Now, unfortunately, we can't subtract out the protein in bone. And people forget that 50% of your bone is made up of protein.
Oh.
Yeah. So the way bone is made, right? First, you make a collagenous, a proteinaceous matrix. It's a matrix, a little gel. Then you seed it with the different minerals. And that's how you make bone. So without the gel, which is the protein that you need to have, without that, it's mostly collagen. If you don't have the protein base, you're not adding minerals to anything. You're not making bone. So, whenever someone gets a diagnosis of osteopenia, osteoporosis, oh, vitamin D and calcium. And I'm like, well, what about the protein? What about the magnesium?
Mm,
There's so many other factors. What about the vitamin K2? I mean. So, but again, we just go, oh, calcium, vitamin D. Oh, it didn't work. Oh, start some kind of medication, right? And we're not thinking in terms of, well, what makes up bone and what do we
right.
need to even make bone, right?
Well, so when I get a DEXA scan, if I ever find one, then does it sort of double the weight to estimate the amount that of the protein that really is a part of the bone?
It would just be counted with everything
Okay,
else.
so the
So,
so the
but it separates out just the mineral content. Yeah.
all right, so the when it says the bone, that's just really half the bone. The other half of the bone goes into the muscle and the organs and the proteins.
Yeah, the collagen base of the bone is going to be counted with the rest of your muscle mass. Yes.
Okay. Okay.
Yeah. Yeah.
Great.
So, okay. So now, as I said, we are looking at at muscle, right? And the main thing is to realize that your biggest glucose sink in the body is muscle.
Mm.
All right. Really important because normally that's how, if you had some carbs, you had some bread, potatoes, whatever, where is it going to go? It's going to go into muscle, and then
Mm.
excess will be stored in fat. But
Mm.
generally, your muscle acts as a sink so that it uses that fuel for energy, for walking, doing your activities, sprinting, whatever you need, right?
Hmm.
Okay. The problem with this is if you think about having, let's say, a big dumpster, and that would represent the volume of muscle mass that you have.
Hmm.
As we age, and you mentioned that your listeners are older athletes,
Hmm.
as you age, we have a condition called anabolic resistance. And so it means it's harder to preserve muscle mass, hard to build new muscle. And generally, it's been accepted that people lose 3 to 8% of their muscle mass per decade.
Hmm.
And that's under the best conditions. Okay, that would just be like the classic ideal circumstances. In real life, we have what we call catabolic crises.
Hmm.
And catabolic crises are accelerated periods of muscle loss and also probably some bone loss, right? An example would be you get sick. You lie in bed for a few days, or you're just not as active. You don't realize it, but you're already in a catabolic state,
Hmm.
right? Maybe you had an injury and you needed surgery, right? Even if you're not bedbound, just to wound heal and repair everything, that takes up energy, and you might be in a catabolic state, right? Sepsis, trauma, those are extreme cases, but those are big catabolic states. There's one catabolic state that no one ever talks about, and that is weight loss. Anytime you lose weight, you are losing muscle. Okay, so people assume weight loss, oh, I'm losing fat. No, you're losing fat and muscle. Okay, and so it's true in bariatric surgery. It's true when you use medication to lose weight. It's true with diet-induced weight loss. Okay, so this is, half of America is dieting the whole time and undergoing a catabolic crisis, and no one ever recognizes this, right? So aside from the normal aging process and life happening to you, you get sick, you get pneumonia, you fall down, you hurt yourself. Aside from that, you're also putting yourself on various diets. Some people might be over-exercising, for example. Okay?
Or people are fasting.
So I'm glad you brought that up, intermittent fasting, right? So people always ask me, well, what do you think? Should I do intermittent fasting? And I think if you're young, if you're in your 20s, you can pretty much get away with anything, right? Let's agree on that. But as you get to the 40s, even the 30s, especially if you've not been very active, I would start to worry. So there was a recent study, it's called the TREAT randomized trial, that looked at time-restricted eating. And it turned out that, basically intermittent fasting, and it turns out that you don't lose more weight with intermittent fasting. But the other thing is there was much more muscle loss.
Oh, boy.
Yeah. And so, that's not a good thing because you're losing. So the average, if you were to, let's say, have bariatric surgery or just go on a diet, generally about 30% of the weight loss is coming from muscle loss. So let's pick an easy number because, I went to med school. I didn't go do math or engineering, right? So let's pick an easy number, 60 pounds. You lose 60 pounds, 20 pounds would be muscle. Okay, now we're in trouble, right? Now think about this. Yes, so we lose 60 pounds, of which 20 pounds is muscle. Now think about this. You will need a lower intake to maintain that weight. And inevitably, people will actually start to regain the weight. But here's the catch. You are regaining all of the 60 pounds in fat. You are not putting on, especially as you're aging because of anabolic resistance, it's really hard to put on muscle. All right. So now you have changed your body composition. You come back to the same weight as you were before, but with 20 pounds less muscle, 20 pounds more fat. On the scale, you wouldn't know. Looks great. Okay. Or at least you say, well, I got back to my old weight, but it's not your old body composition. That's the biggest problem that people don't realize, right? So weight loss is something that you have to think about very carefully because you're sacrificing muscle mass the whole time. So besides what you said about intermittent fasting, the other thing I worry about in athletes is a lot of people, especially as they get older, the sports that they tend to gravitate towards would be more the endurance types. Whether it's biking, whether it's running. I had someone who was a cross-country skier, and that was his sport, right? The endurance sports are actually going to, make it hard for you to keep muscle.
They're catabolic, sure.
Yes. So as I started saying, you have a dumpster that represents the volume of muscle that you have, right? And now you actually shrink the muscle mass. So now instead of having a big dumpster, you just have one garbage can size of muscle. And what's going to happen is glucose is going to spill out. It used to be able to go into the dumpster, but now you have a much smaller can, right? And the excess spills out. Now, what happens is people say to me, but I didn't change anything, Dr. Loh. I'm eating the same thing. I'm doing low carb, but you have less muscle. Okay. And the glucose has to go somewhere and it's going to spill into the blood.
If you eat it, it's got to go somewhere.
Yeah. So that's the key, right? We at least have to preserve the muscle mass. But as I said, if you're really engaging only in the endurance sports and overdoing that component, then you're going to make it really hard. And I've seen some diabetics, right? They have, their A1Cs 8, 9, 10. they're doing time restricted eating, they're, biking all day and competing and so forth, supposedly very fit. I had one doctor tell me, but my patient's really fit. I'm like, fit for what? Right? I mean, fit. I hate that term because it really depends. It's specific to a certain sport, for example, right? So yes, he's a good biker, but why is his insulin, why is his blood sugar climbing? Why is his A1C now 8, 9? Right? It's because, well, he's biking all day. He's only eating one meal a day. He has no muscle, right? And if he keeps doing that, his blood sugar is going to keep going up. And people don't understand that because they're always thinking, oh, the pancreas is failing. I said, no, your muscle is failing. But you'll never get a doctor to think about the muscle. I went to a cardiometabolic conference and this woman kept going on about how it's some cryptic form of diabetes, right? And meanwhile, she made the point that her, so she has this cryptic form of diabetes. And she's telling everyone her BMI is 19. So she can't be like the regular diabetics because she's not obese. And I'm like, lady, you have no muscle. I'm watching her on the stage. I'm like, you ever consider that that's where, the glucose has to spill out because you have no muscle? No, she never thought of that, and, I just don't have the breath sometimes and patience. It's a conference. I didn't want to, like, she was on the stage and everything, but my point is that nobody thinks about this.
Yeah.
And then we miss it, right? And the next thing you know, you're on a medication. Now, once you become diabetic, I want to point out that leads to accelerated muscle loss because diabetes itself, with the excess sugars in your blood, that is inflammatory and toxic to muscle. So now we have a catch-22 and a vicious cycle, and you're destroying more muscle as you have less and less blood sugar control.
Is this maybe where sarcopenia is coming from?
Yes.
I mean, there's this inflammation from the fat, and then there's an inflammation from the blood sugar, which is, as the muscles shrink, then there's more blood sugar and more inflammation and less muscle. And
sarcopenia, a lot of times is associated, what we call, we talk about sarcopenia as low muscle mass and also low muscle strength. Then we talk about obesity as excess fat. And then we talk about osteopenia and osteoporosis as low bone, right? Low bone mass. But really, the condition should be thought of as osteosarcopenic obesity. In other words, low bone, low muscle, high fat. And now you realize that you can't look at obesity from the point of view of a stupid number on the scale. You really have to look at all the metabolic tissues. You have to look at fat, obviously, but you must look at muscle and you must look at bone because they are interacting. Not only is the fat influencing the muscle and bone are influencing the fat, and they're sending signals and hormones to each other to talk to each other, right? And so there's this definite crosstalk between these different metabolic tissues, and then they all signal to the brain as well. So it's not in isolation. And one of the reasons that people, that we've treated obesity so poorly is because we just focus on one component. And we're not looking at the metabolic spectrum of this disease.
Is there any answer other than to get people to exercise and build their muscles?
It is definitely to look at exercise, but we have to be specific. It has to be resistance training because, again, overdoing the endurance training is too much. To get rid of the visceral fat, I generally add in some metabolic conditioning, but I just have maybe 2 or 3 pulses of that in the week for the patient. And then we have to have adequate protein intake. Okay. So we really have to max out your protein because it's going to require more protein to give you an anabolic kick, an anabolic stimulus. So a young person in their 20s, 20 grams of protein will go far. Someone in their 60s, 20 grams of protein may not do much muscle synthesis. You may have to go to 35 or 40 grams per meal.
Okay, so a dose needs to be big, and how many doses? I suppose it has to do with how big you are.
Well, I generally, yeah, because it's per kilo, yeah, grams per kilogram. But I generally do kind of think about in the range of 120 to 150 grams of protein per day, divided into 35 grams per meal, right?
Okay.
So because if you only eat 10, so I have a lot of protein, Dr. Loh. I have an egg for breakfast. Well, that's 7 grams.
It's not
Okay.
much.
That's 7 grams. Good luck. And if you have an egg white omelet, well, just that's 5 grams, right? Because you took away the yolk and all the other good stuff. So here we go. People not getting enough protein, but per meal, I'm aiming for 35, minimum 30, but 35 for my older patients per meal, because
Okay.
under that you don't get maximum protein synthesis. I'm trying to increase that, right? And then I have to dose it out, so they're eating 4 or 5 times a day. That's number one.
Okay.
Number two is back to intermittent fasting. The second biggest problem I have with it is with intermittent fasting. Talk to anyone. Go ask any friend of yours who's doing intermittent fasting, right? And ask them, what time is your first meal?
Yeah.
Yeah. They're always going to tell you lunch, noon, 2 o'clock, right? It's always
Right.
late. So
Right.
just think about it. You go to bed and you don't eat all night. That's your biggest catabolic window. Great. Let's extend my catabolic window,
Yeah.
right? As soon as I get up, I'm just going to wait another 5 hours and extend it by another 5 hours. I'm like, good Lord.
The problem is that that's the time that's the easiest to
Yes.
skip. And I think people feel like it's helping them control their weight, which
Yes.
is important, but you're
Yes.
saying that it costs them on the protein side.
Yes. And remember, if your weight, right, is the same, or you're going down on the weight, you have to ask yourself, what is going down? Is it fat? Fat and muscle? That's most likely the case, right? And how
Yeah.
much muscle? So just looking at the number on the scale isn't the solution. In fact, it may, as I said, losing weight may make you sick and fatter, because when you regain the weight, your body composition will change,
Okay.
right? And then just to tie it in, because we did muscle, let's look at bone. And again, bone, as I said, secretes a lot of hormones. We think of bone as structural, which it certainly is, but it's highly metabolic because it's secreting all these hormones. And then people forget that, your blood cells, your immune cells are all born in the bone.
The marrow.
So it's highly related to your immune system. No bone, no immune system, right? And then the other component that people never think about is the fat in the bone marrow. And that has implications in terms of inflammation and so forth.
Right. I have heard that the fat cells start to crowd out the stem
They
cells.
definitely do. So we convert from what we call red marrow. So red marrow would be when you're young, you have a lot of these hematopoietic stem cells that make the red blood cells and also your white blood cells. But as we age, by the time you're 7, you start to replace the red marrow and you get more and more of what we call the yellow marrow, which is fat. And you do have a certain amount of fat, and they act as also deposits of fat stem cells. So when you gain weight, and now here's where it gets a little complicated, but some of the remember I told you make baby fat cells in the subcutaneous compartment. Well, normally you want those baby fat cells to come from the stem cells within the fat, right? But in cases of obesity, a lot of those stem cells are coming from the bone marrow. And those then develop into inflammatory fat. So even being in the subcutaneous compartment, over time, you get into trouble. It does get very complicated. I mean, I love talking about fat. You go forever because it's very plastic. The other thing that people don't realize is that fat can become muscle. It can change into fibroblasts and scar, but the scar tissue can revert back to a fat cell, right? We see that in breast tissue, what we call pink fat, right? So we realize that the fat cell is highly plastic and can modulate into different cells. Your fat cells can even change into immune cells. It's pretty fascinating. right? And it secretes all kinds of substances and makes little packages, membrane-bound packages that we call exosomes, and send mRNAs to different parts of your body, right? So fat is highly interesting, very complex, and really determines, I would say, a huge part, majority. I'm going to risk, saying the majority of your metabolism. If we were to study fat, we'd realize, oh my God, it rules all. And it's not surprising because, we became Homo sapiens because of fat. We are the fattest primates, right? Bonobos, for example, have 4% body fat, and that's normal for them. 4% body fat for us would be terrible. I told you about that already.
Mm-hmm.
And the only reason we became Homo sapiens is because our brain sizes grew. And that was because of fat, right? And the reason that we store fat in our body and we are fatter than other primates is because our brain is bigger and we need that supply of fat, especially when growing a brain. And we always think about, oh, babies in the womb, but that brain is growing from the time it's born till the 20s. And it requires that amount of fat in your body to supply it with enough energy. And nobody thinks about that either. Right. So when they talk about childhood obesity and just give them surgery and I'm like, I got some news for you. Most times, even in cases of starvation, where they have nutrient deficiencies, let's say if you look at kids, and studies were done primarily in Brazil and also in India, where they looked at kids that didn't get enough nutrition. And interestingly, they kept their levels of fatness. And the way they did that was stunting. So remember, your BMI is weight over height squared in metric units. So the way to keep the level of fatness is to decrease your height, right? You keep your adiposity or your fatness level. And stunting is really an adaptation of the body to low nutrient conditions. So when they talk about treating obesity in kids, I'm like, you think about the body composition, anyone? And that's never discussed. Very frustrating for me because I'm just like, I'm not a pediatrician, I'm worried. Shouldn't the pediatricians be worried?
Yes.
And shouldn't you be advising parents before your child goes to bariatric surgery or use of medications that stunting might be a side effect?
Oh boy. Okay, I see we're running out of time here, and I want to give you a chance to wrap this up. It seems like once a person has gotten to where they are obese with low bone density and low muscle mass, they're in trouble, and they've got a tough row to hoe to get back from that if they can. But a person who is just starting to put on weight and just starting to lose some muscle mass, it's not too late. And they should do what to get back on path?
It's not too late for most people. I even, treat people with morbid obesity and, they have come to a really good place. The main
Good.
things to remember would be we need to make sure you don't have obesity, whatever your weight, number one, right? And then if you do have obesity, the main thing to figure out is where is that fat located? And we got to get rid of the metabolically unhealthy fat first. It's very, very responsive to exercise. That's the great news. It's highly responsive to exercise.
And that's
And so,
responsive to both resistance and endurance training?
yes.
Okay.
So I would say for your audience, they're already doing the right thing. I would definitely balance out the resistance and the endurance components because
Okay. So do both.
I actually tend to cut the endurance to quite a bit lower than the patient is used to. So I generally will start with 3 days of resistance training. If you're much healthier, maybe we can go to 2 days, especially if you're an endurance athlete and you need the endurance for your sport. Then I would say, okay, 2 days. I like full body. Okay. People do the split, upper, lower, front, back, that kind of stuff. I like full body because I believe you have a higher metabolic challenge with full body.
So a better signal to the
Yes,
body.
yeah. So I generally would prefer a full body program for those 2 to 3 days. Okay, and then the days that are in between, I prefer high intensity interval training. That's great for visceral fat. Okay, so you want to add in intervals there. Yeah, and I usually will ask for 2 sessions in my patients. If you're doing only 2 resistance training sessions, then you could probably have 3 of the high intensity. And I limit those. Yeah, really don't like to go beyond 30 minutes if you're doing real intervals, right? Some people want to go longer, 40, 45 minutes, okay. But again, we're playing now with that edge on, where's your muscle mass, okay?
Plus, it's also very stressful on the
It's very
body.
stressful. Yeah. If you're doing it right, if you're truly doing intervals, it's not easy. You know, for myself, I've done like 1 minute burpees nonstop, and it's really, really taxing. And you should feel like if you're doing the intensities right, the intervals correctly, you should feel like, you're about to throw up, right? When they do
How
those,
fun.
yeah, when they do those tests, those intervals, when you see that in exercise physiology tests, first of all, they use young men in age 20, but they get them to the point where they are literally vomiting into a bucket,
Yeah,
right?
I've done that.
Then we say, oh, we just did jumping jack. That is not high intensity training, right? Right. So I just want people to know what they actually do in the studies. But anyway, adding in, and you don't have to do that. No, you don't have to make yourself buff, but you do want to get your heart rate up. You do want to have increased exertion, right? And I use the breath test. You shouldn't be able to talk. You should be, just, I really don't want to say anything, right? So if you get to that point, you're at the right intensity.
Okay.
So I would do that maybe 3 days a week if you're doing 2 resistance days, right? And now we're at 5 days. So I'll have one sort of slow, steady kind of cardio day, and then a mobility day.
Okay. So no days off from activity, just mix it up.
Yeah, I think, in this day and age, in urban communities, I don't think you need a day off. I really don't, because most of the time we're just sitting, right? And
Good.
I think we need to move a bit more. And then the protein, Joe, they've got to eat protein, and they've got to prioritize. And I prefer animal sources, just to add that in, because the plant sources, I mean, first of all, to get enough, you'd eat a whole tub of tofu, and that's barely going to get you to enough per meal.
Although they can buy like pea powders and.
Yeah, but the bioavailability isn't as great.
Oh, okay.
Okay. So I tend to just look, if you've got sarcopenia already, and especially as you're aging, I don't play around. We gotta reverse this because it takes time. It's not easy.
Okay. Fair enough. And so you don't recommend intermittent fasting. And I suppose that means you also don't recommend like 24-hour fasting or 3-day fasting, water fasting.
I don't feel like my patients, and as you get older, even if you are healthy, I don't think that's something that's worth trying, because, you're going to lose mass. You just will, and I do worry about that. The other thing is sleep, right? You are not making muscle in the gym. You're making it at night when you're sleeping. That's
When you
when,
recover.
yeah. So if you don't have good recovery and your sleep is poor, your circadian rhythm is off. So all these people who like change their sleep schedule on weekends, right? So say you wake up every day at 6, and then on the weekends you wake up at 9. Well, you just traveled from New York to California. You just had jet lag, right? And then on Monday you're traveling back, and you do this every week, every week. This is taxing to your body, and you'll never set your clock, right? You never set your circadian rhythm. So you get into trouble that way too. And like I said, when we're talking about muscle, I don't play around. They need to sleep. I also make sure, I don't care how skinny you are, if you tell me your sleep is disturbed or you have hypertension that is resistant to medication, right? Then you need a sleep study. And I don't care how skinny you look. You need a sleep study. I have never been wrong. All my skinny people went and had the worst sleep studies.
Like they had sleep apnea
Yeah,
or what?
sleep apnea. Yeah.
Terrible. Okay. All right. And anything else like supplements? I mean, you talked about maybe protein powders. I suppose you would be in favor of, but anything else that might help people, like creatine, maybe?
I do sometimes use creatine. Yeah.
Okay.
So I think that's helpful. I mean, it really depends. I mean, sometimes you have someone who's more on the vegetarian end, and I like to, throw in a little bit of creatine just to help them out. But I try, and I do like using fish oil, but
Okay.
I will say the antioxidants, be very careful, okay?
Uh,
Because the whole idea of exercise is to create stress,
yeah.
metabolic stress. So all these people like taking the antioxidants right after the exercise, I'm like, hello, honey, we need the stress. We need
Yeah.
some inflammation in the muscle. So I always write, I hate it when people go, oh, yeah, we got to get rid of the inflammation. No, there is always inflammation and anti inflammation, and it's a balance, and you have to have both. And especially
Right.
when it's muscle, you went to the gym. We just did that specifically to create inflammation. Now you're going to take that antioxidant. You just wasted your time. Okay.
Yeah.
So,
Yeah.
I mean, the studies are clear. So, for example, with vitamin C, right, you don't want to take that right after you exercise. I at least wait a 6 hour window, 4 to 6 hour
Okay.
window. Yeah.
Okay, good tip. One last thing then. More and more people are having sex hormone level issues. Maybe that's related to too much body fat, but it could be, sleep. It could be all kinds of
Yes,
things.
absolutely.
And, not having enough testosterone, maybe that's behind their low
Yes,
muscle mass. What,
absolutely. So
what,
that
do- what do
means
you recommend?
I think that, again, definitely if someone has problems with sexual function. So I just did a video on erectile dysfunction. And
Uh-huh.
unfortunately, most people think it's just erectile dysfunction. I'm like, no, when I see a patient with erectile dysfunction, I'm thinking, oh, heart disease
Yeah.
immediately, right?
Yeah.
It
Blood
means you have
flow.
heart disease. So you do need, included in the assessment, you should have your testosterone tested, right?
Okay.
And I think that that's probably true, but there's also, as you mentioned, a lot of hormonal imbalance with obesity. So
Yeah.
that, makes the problem a whole lot worse because it
Yeah.
changes the hormonal balance.
Okay. So it's just another layer of complication that you've got to get to the bottom of.
Yes.
The answer is you have to solve it to,
Yeah,
or you're
absolutely.
going to have metabolic
Yes.
unhealth.
I think
Okay.
your listener population, all the things that I mentioned, if they were to just kind of tweak those things, that it would get them to a much better place.
Well, this was great. Thank you very much, Dr. Loh. Can you tell our audience how they can find you, more information about, you mentioned your podcast and your practice. You're in the Boston area. Tell us about that.
I am in the Boston area, but I also have a coaching platform, and
Mm,
that's on tulaversity.com,
great.
TULAVERSITY.com. And what I do there is there we put people through a 3 month program, and I do have different videos where they learn about metabolic health, they learn about the fat, they learn about muscle and so forth, right? And we put them on an eating schedule, we put them on a sleep schedule, just to help them start to regulate their metabolic health.
Okay.
And generally, that's how people work with me. They can do that from anywhere in the country, and we help them and give a very structured approach to improving their metabolic health. And then I also do some consultations just to guide the medical treatments for people who may have complex care or chronic conditions. They need extra help. Sometimes it's really hard to get to see a doctor these days,
Mm.
and people struggle with fragmented care. So I help them put the care together and kind of guide the treatment in terms of what tests should be done and what I think should be the treatment plan for the person.
Awesome. And when is your book going to come out?
Well, I'm working really hard on it, and it is on body composition. So I hope in the next few months I'll get it done, and then we'll see. But
Fantastic.
my website is VyvyyaneLoh MD.com, and as you know, my name's spelt a little differently. It's VyvyyaneLohMD.com. So they can kind of sign up for my newsletter there and follow
Yeah.
me there. And like you said, my podcast, VLMD Rounds, that's 2 words. I am also very shortly, hopefully by the end of this week, I will have launched my new channel on YouTube. And that
Nice.
will be specifically so VLMD Rounds is more for a technical audience, professional audience, doctors and things like that.
Oh,
Although
okay.
I have plenty of people who are interested and just kind of, they slog through the technicalities there. But the new channel is going to be for the lay public, where we talk
Oh,
about things like body composition, and I just break it down in simple to understand terms, no jargon, and give out health tips on what to do to improve your metabolic health.
fantastic. Well, I'll get all those links in your YouTube channel when you know it. Maybe you can already tell me what that is, and I'll put that in the show notes so people can just go for the links there.
Yeah.
Dr. Loh, thank you very much. This has been very educational.
It was a pleasure.
Alrighty. Have a good night.
Thank you.
All right. Bye-bye.
Bye.
Thank you so much for joining my conversation with Dr. Vyvyane Loh. You can find more information about Dr. Loh in the show notes.